We would like to call the next speaker now, Sabia Handa, and she'll be speaking on submacular haemorrhage displacement using subretinal RTPA and air versus subretinal balance salt solution and air, a comparative study. And Dr. Rajiv Reddy will be the discussant for this topic.
A very good evening to everyone. So,
excuse me, 1 minute.
Yes, sir. Yes, ma'am, this is MCH thesis.
We raise this up. So ideally they should not even give a certificate, it cannot be taken there. Maybe she doesn't complete. Sorry. You are above all the pages. Yeah.
Thank you. Okay.
So, what is the final decision?
She can present, but she will not be evaluated for the award.
Okay.
Don't get disheartened.
No, ma'am. Thank you for letting me present. So, submacular hemorrhage can occur secondary to wet ARMD, PCV, myopic CNV, or retinal artery macronism. And the natural history and the visual outcome of these hemorrhages are typically poor. So, early displacement of these hemorrhages from macular area is recommended to restore useful vision. And various techniques have been described in the literature for the management of these large submacular hemorrhages, ranging from surgical evacuation, intravitreal gas with or without TPA, to PPV with subretinal TPA injection. However, currently there is no consensus or treatment guidelines regarding the optimal management of large submacular hemorrhages. So this study was designed with an aim to study the role of subretinal balanced salt solution as a substitute to TPA in the management of these hemorrhages. TPA, as we know, is expensive and is not freely available. And for the purpose of study, the fundus was divided into these 4 zones. So coming to the primary objective, which was to see the displacement of hemorrhage from baseline at 1 month, and to the secondary objective was to see the change in BCVA from baseline within each group and between 2 groups at 3 months. And for the purpose of study, the eyes were divided into 2 groups. The outcome was assessed in terms of complete success, partial success, or failure, in which when the hemorrhage displaced from both zone 1 as well as zone 2, it was termed as complete success. So the following was the inclusion criteria. Only the large submacular hemorrhages of less than 2 weeks duration were included. So this was an ambispecative, non-randomized interventional study in which the eyes were divided into 2 groups. Group A patients underwent PPV with induction of PVD, followed by injection of TPA and 0.2 ml of air, followed by partial FAX, 20% SF6 tamponade and heads-up positioning. In Group B, the entire procedure remained the same, except that instead of TPA, subretinal BSS was used. And this is a small video demonstrating the steps of surgery. Following the Parsina vitrectomy, a subretinal cannula is used to inject a mixture of either TPA and air or BSS and air into the subretinal space. And this is followed by partial fluid air exchange and SF6 tamponade. So coming to the results, 10 eyes were included in Group A and 11 in Group B. And we can see that the most common cause of hemorrhage was PCV in both the groups. And coming to the primary objective, 9 out of 10 eyes in TPA group and 9 out of 11 eyes in the BSS group showed complete displacement from zone 1 as well as zone 2. And as far as secondary objective was concerned, there was a significant improvement in visual acuity in both the groups, and the visual acuity gain in both the groups was comparable. So coming to the case example from Group A, this was a female with the wet ARMD. We can see that there was displacement of submacular hemorrhage. However, the visual acuity remained guarded due to the subfoveal scar. And this is a case example of a patient from the BSS group. We can see here that the submacular hemorrhage has been displaced, and the visual acuity gain has improved from hand motion to 618. So to conclude, PPV with injection of subretinal BSS and air is effective in displacing large submacular bleeds in patients presenting within 2 weeks of symptoms and is comparable to TPA. However, certain limitations are that this is an ambispective, it's not a prospective study, it's a non-randomized study with a small sample size, and toxicity of either BSS and TPA could not be assessed in the study. I would like to thank my mentors, especially Dr. Mohit and Dr. Amandeep Singh, for helping me carrying out this thesis. Thank you.
Thank you. Dr. Rajiv Reddy.
Sir, in for TPA, we have seen that in patients who have undergone subretinal TPA injection, in higher doses, there can be some autofluorescence changes and damage to RP and photoreceptors. These changes appear as hypoautofluorescence on autofluorescence imaging.
Did you take an autofluorescence pre and post? Did you take a
Sir, that
autofluorescence
was
pre and
one
post?
of the limitation. We could not do autofluorescence pre and post for all the patients. I mentioned in one of my limitations.
So what about subretinal and sub-RP hemorrhages?
Sir, so in these patients, even the patient with sub-RP hemorrhage were included, but that cannot be displaced. That we didn't carry out the study for sub-RP hemorrhage, only for submacular hemorrhage.
Because I saw a patient where you saw sub-RP hemorrhage is more
Yes,
of.
sir, that we cannot displace anyway. But the patients were included in both the groups.
Thank you.